Hello and welcome. I'm Joe Saramelli, and I oversee grand rounds for the Department of Psychiatry and Behavioral Sciences. And thank you for joining today's grand rounds presentation. For this academic year, we've decided on a theme for the grand round series called Next Steps in Care, which is a series of presentations on innovations and updates in clinical care, which can include where care is delivered, which is part of what we'll hear about today as well. So there's a core group of us working on grand rounds, which includes Samhar Abraha as the grand rounds coordinator and who does communications, and Mike Walker, who does the technology parts of grand rounds. Our grand rounds presentations are archived on our grand rounds website, which is linked here. And remember that today you can submit questions throughout the presentation by typing them into the comment area, and we can go through questions at the end. So funding for the Grand Round series comes from the Ripley Fund and from various institutes or centers in the department, including the Garvey Institute for Brain Health and Solution. At the end of the presentation, please complete the evaluation. I'll put the Grand Round speaker evaluation in the chat towards the end of the presentation. And now on to talking about today's presenter, Dr. Sydney Hankerson. Dr. Hankerson is Associate Professor of Psychiatry at Columbia University Irving Medical Center and co-director of the Columbia Wellness Center. Dr. Hankerson works clinically in the New York Presbyterian Charles B. Rangel Community Health Center. It's a federally qualified health center, and is co-chair of Columbia's Anti-Racism Task Force. Some background: Dr. Hankerson completed an MD MBA program at Emory University, completed psychiatry residency at Emory, where he was also chief resident, and then completed an NIMH T32 research training fellowship. And since then, Dr. Hankerson has developed and collaborated on a body of research generally aiming to promote mental health equity, and specifically doing this through novel church-based depression interventions, focusing on engaging Black men in depression care. And Dr. Hankerson's work is supported by the NIH and other organizations. And for this work, he has received several awards, including the Solomon Carter Fuller Leadership Award from the Black Psychiatrist of America in 2016. So Dr. Hankerson has also presented his work at a White House dialogue on men's health in 2016, and more recently was appointed by the New York City mayor as chair of the Community Services Board of the New York City Department of Health and Mental Hygiene in 2021. Well, I'll stop there for now and turn it over to Dr. Hankerson, and we'll go through questions at the end.
Thank you, Joe, so much for that very warm introduction. It's truly an honor to be here today as Grand Rounds presenter for the Ripley lecture. So I will go ahead and share my screen. Oops. Okay. So as Joe mentioned, my work really focuses on promoting mental health equity. And today I'm going to share some of my work specifically focused on engaging Black churches as a way to promote mental health equity. First, would like to thank you all's esteemed chairman, with whom I was able to connect briefly before today's talk. My dear friend and colleague, Pamela Collins, all her mentorship when she was at Columbia, she was just a tremendous mentor to me. I want to thank Nancy Grote on your faculty, who I had the pleasure to meet several years ago at a conference in Seattle. And a special thank you to Dr. Richard Veith, who I met several years ago. His son David is at Columbia, and I met him, and he wrote a very nice note prior to today's talk. And also want to thank Samar and Mike for their just making this such a seamless transition and preparing for today's lecture. And then certainly want to acknowledge all of my mentors and collaborators at Columbia and elsewhere. And a special thank you to the Community Coalition, which is the advisory board for all of my studies. So since, my work is really grounded in community engagement, if we were meeting in person, I would, start with an icebreaker to try to get people connected. And so in lieu of that, in this virtual environment, I'm going to ask all of you to reflect upon the story of your name. So who named you? What does your name mean? And how does your culture influence the meaning of your name and any other historical aspects of your name? So just reflect upon that for 30 seconds. And I'll set my Apple Watch now. Okay. Thank you for participating in that and reflecting on the story of your name. When I do that with medical students in person, when I teach them a course called Access and Advocacy, several themes inevitably emerge. Some people say that they never have thought about the story of their name. Some people say that their parents actually changed their names when they immigrated to this country to become more westernized or more European. Some people talk about how they are first generation in this country. And some people talk about their names being passed down from generations. And so since I asked you to do that, I wanted to share the story of my name. My full name is Sidney Herbert Hankerson III. And so I was named after my father and grandfather. And Sidney, my name literally means south of the water, for whatever that's worth. But the story of my name is really the story of the Jim Crow South. My grandfather, who I'm named after, grew up in a small town in Georgia. And he only has an 8th grade education. He had an 8th grade education because at the time, they did not build high schools for Black youth. So he only had an 8th grade education. He worked menial jobs kind of as a laborer throughout his life. And he really impressed upon the importance of education to my father. Now, my mother's side of the family, my mother was born in Aiken, South Carolina. She's the oldest of 7 children. But when my mother was born, Black adults were not permitted to give birth, to deliver in hospitals. As you can imagine, the infant mortality rate was extremely high because of lack of access to prenatal care and other healthcare services. And 3 of my grandmother's 7 children died before they were 3 months old. And so the impact of Jim Crow was felt upon both of my parents. And so my parents actually met in college in Atlanta, and my dad being from kind of the big city in Fort Lauderdale, Florida, and my mom being from this small town in South Carolina, kind of the country mouse, and my dad, the city mouse. My dad said, if we have a son, I'd like to pass on my name to him. So I became Sidney III. And that is the story of my name. And I share that story at the outset to introduce some of the structures and systems that have impacted mental health care and that we've been increasingly made aware of over the last 2 years. So during our time together, I've broken this presentation into 3 main sections. The first, I'll quickly go over some racial disparities in depression care. My research and clinical focus is depression. And then second, I'll go over the feasibility of kind of why the church as an alternative setting to formal mental health clinics. And then go over, lastly, this notion of community partnered service delivery as a way to address these disparities in care. So we all know that major depression is debilitating, and study from the World Health Organization a few years ago showed that it's the #1 cause of disability worldwide. And the relationship between depression and race is a complex one. This data is from a national epidemiological study called the NESARC, and it shows what has been consistently kind of replicated in many national data sets, that African Americans have lower rates of lifetime depression and slightly lower rates of 12-month depression compared to non-Hispanic white Americans. However, when African Americans are depressed, they are more impaired or more disabled compared to their non-Hispanic white counterparts. This data is from the National Survey of American Life, which is the largest epidemiological study of depression in African Americans. And it looks at Sheehan Disability Scale scores between Black and white adults. And you see that African Americans with depression had higher disability scales in work, in relationships, in social functioning, and in overall functioning. And so indeed, depressed African Americans have more severe symptoms, self-rated severity of symptoms, and are sicker for a longer period of time compared to non-Hispanic white Americans. So depression is a severely disabling condition in the Black community. And you would think that people in the African American community would be running out to get care. But unfortunately, we know that's not the case. African Americans and Mexican Americans have the lowest rates of depression treatment in the country. And I'm sure that you all know many of the causes of mental health disparities and inequities, many of which are linked to socioeconomic inequalities and to structural factors. So I'll just focus on a couple of these factors. One is clinician misdiagnosis. So there's a pretty robust body of literature which shows that when African Americans have psychotic symptoms, they're more likely diagnosed with schizophrenia or schizoaffective disorder compared to white Americans, who are more likely diagnosed with major depression with psychotic features or bipolar disorder with psychotic features. And to illustrate this, this is actually an ad from a medical journal in the 1970s, where you see the tagline, assaultive and belligerent, and a very Afrocentric looking man who to me looks just like James Brown. And then kind of the tagline, cooperation begins with Haldol. So we as clinicians have contributed to some of these inequities in distrust and care because we are, of course, the diagnostic instruments. And so it's important that we own our own unconscious racial biases that may seep into our diagnoses and to ultimately our treatment plans. And then certainly the murder of George Floyd just increased America's awareness and really reckoning with racial injustice. And there was a study that came out several years ago in The Lancet that showed that when African Americans are exposed to a member of the Black community being killed by police, they have poor mental health outcomes compared to white Americans who witnessed someone killed by the police. And so this past almost 2 years has been just a recurrent exposure to kind of community level trauma in the Black community. And this trauma has certainly been heightened, and these structural inequities have been heightened by the COVID-19 pandemic. Certainly it's been well documented the disproportionate number of infections, hospitalizations, ICU, and deaths, tragically, in the Black community from COVID-19. And so I certainly want to emphasize the role of structural racism as really a driver in some of these disparities in depression care. And while there's no one agreed upon definition of structural racism, I really like the framework as outlined by Camara Jones, which is kind of highlights the 3 levels of racism at the institutional level or systemic racism that prevents access to goods, services, and importantly for our purposes, healthcare, education, and employment opportunities because of a person's race. That was evident by my grandmother not being able to deliver her children in babies and in hospitals because of her race. And then, of course, individual level racism, which is personally mediated racism, someone calling someone else a racial epithet, or the microaggressions that have become so commonplace, or people have become so aware of, especially in academic settings. And then perhaps the most nefarious impact of racism is internalized racism, which is the self-doubt, the feelings of hopelessness, and feelings of inferiority by groups who are impacted by structural racism. And so because of certainly the connection to socioeconomic conditions and limited access, structural racism or racism is really a driver of these disparities in care. All right, so that's kind of a quick overview of some of the factors that contribute to racial disparities in depression treatment. So the next section I'll go over, why the church as a setting to try to increase access to care. There was really a landmark study that came out almost 20 years ago now from the National Comorbidity Survey that showed that when people in the United States, regardless of their racial or ethnic background and regardless of their religious affiliation, when they're first experiencing a depressive episode, first experiencing symptoms of anxiety or any other mental health condition, where do they first seek care? And behind mental health professionals, which this study classified collectively as psychologists and social workers, the group that was most often sought first was clergy. So pastors, rabbis, imams, and faith leaders are really frontline mental health professionals. And people seek care from clergy more often initially than they seek care from primary care doctors or from psychiatrists. And the role of the church in the African American community has both historical and cultural significance. African Americans are the most religious group in the United States by every measure that is used. 87% of African Americans belong to a religious group. 79% say that religion is important, and over half attend church at least once per week. And so given the reliance on clergy as a source of support when experiencing symptoms of depression, and given the frequency with which African Americans attend church and the cultural significance of the church, I thought that churches could be viable settings in which to attempt to implement evidence-based care for depression. And at the same time, at least in the Christian faith tradition, had to acknowledge that while churches may be key entry points to engage people in care, there also is a history of hurt, neglect, and harm to people with mental health conditions in some houses of worship. Oftentimes, some houses of worship will say that people with depression are depressed just because of personal sin, or because they just don't have a faith. They don't have enough faith. So they just need to try harder or pray more. And it's also important to note that folks who identify as LGBTQ or who are gender non-binary or gender non-conforming individuals have been tremendously harmed by religious institutions. And so while acknowledging the importance and the access that churches could provide when embarking upon this journey to try to partner with churches, we also had to be mindful of how churches have been harmful and have used sometimes religious theology to be harmful to folks with depression, as well as to folks who identify as LGBTQ. And so to see if it was feasible to implement, depression services in faith-based settings, one of the first things that I was fortunate to do, the first grant that I received, was a NARSAD Young Investigator Award. And in this study, I wanted to explore, was it feasible to conduct church-based depression services? So we conducted focus groups with 21 pastors, the majority of whom were women. It was a very highly educated group of pastors. Nearly 90% had a master's degree or higher. This was from a huge church in New York City that had over 20,000 members. So a tremendously vibrant and well-resourced congregation that was in the African Methodist Episcopal denomination. And these findings were published in 2013. And again, very highly educated cohort. But even then, the pastors talked about the impact of institutionalized racism. And instead of conceptualizing depression as a medical illness, they conceptualized depression within the context of structural inequities and kind of community stress that impacted the Black community. So they really impressed upon us that the importance of addressing some of these structural factors and called out racism by name. Another key finding was their perception of cultural discordance with the formal mental health system. This pastor said, as African Americans, we just never get help. And we think that counseling is not for us, it's for that other culture. Implying that in the Black community, there was this perception that, therapy was more for white Americans and not for African Americans. So that was a significant finding as well. And another key finding was the importance of partnerships. I remember one of the pastors said to me, Dr. Hankerson, we like you. You seem to be a nice enough guy and you seem to be sincere, but you're not just going to drop in here, do a study, and then leave with the results. But you have to partner with us for there to be any chance of any type of initiatives succeeding. We don't want you using us like guinea pigs. And of course, that was a reference to the infamous Tuskegee syphilis study. So these key findings from the focus groups really helped to inform the next phase of this work. So leveraging the partnerships that we developed with the pastors at this church and several other churches, we conducted the first ever church-based depression screening study with a validated instrument. And we used the PHQ-9, which I know is the most commonly used measure in collaborative care and in other settings to identify people who had a positive depression screen, which we define consistent with the literature as a PHQ-9 greater than 10. And so the demographic samples of this study, again, which was conducted across 3 different churches in New York City, we screened 122 people. We were able to engage nearly 50% of the sample were men, and the average age was 54. And you see a very wide range of household incomes, again, which emphasizes the fact that people who attend church really cut across the socioeconomic spectra in the Black community. Similarly, in terms of education levels, 48% of the sample had graduated high school and 47 some college or technical school. So a relatively not an uneducated sample. And similarly with health insurance, 88% had at least some type of health insurance. And so our findings had 2 important points. First, the rate or the point prevalence of a positive depression screen in this sample overall across these 3 churches was 20%, which is nearly 3 times higher than that which you would see using the PHQ-9 in community samples. and really rivals the rate of depression screen seen in primary care settings. Another important finding was that 23% of the sample of men screened positive for depression. And although this wasn't a statistically significant difference, we were quite surprised to see a higher rate of depression among men, because traditionally women have 2 times the rate of depression compared to men. So it showed us it was not only feasible to screen for depression in the church, but there were significant unmet mental health needs as it related to depression. And so that brings us to kind of where we are today, trying to address and leverage the partnerships that the pastors told us about were so essential, which led us to conducting the PHQ-9 screening. And then, which brings us to where we are now, this notion of community partnered service delivery. So community partnered service delivery really is centered or grounded on 4 key principles. One is community partnered participatory research, which is a term coined by Ken Wells, who was a mentor on my K Award, and the late Loretta Jones. It also integrates implementation science and this notion of task shifting, basically equipping non-mental health professionals or lay personnel to provide brief evidence-based interventions. And ultimately, the goal is to build capacity in the target community. And again, this is kind of the overarching framework of community partnered participatory research. And the core pillars of this type of research methodology are empowerment, so really empowering the target community, 2-way planning between academicians and community members, equality, and respect for diversity. And Ken Wells, through his groundbreaking Community Partners in Care study, has shown that this type of approach has been demonstrated to increase participation, especially in people of color who are historically distrustful of engaging in research. It builds trust with the target community. It does build capacity, and it reduces depression disparities. And so using this kind of framework, and under Dr. Wells' leadership, I created a community coalition for mental health in Harlem, New York, that provides community-based leadership for all of my studies. The Community Coalition is really a multidisciplinary group of physicians, of social workers, psychologists, pastors, of people with lived experience with both depression and substance use disorders, and members of our local health department. And we have met starting in 2014, a series of months to kind of come up with 3 overall goals to promote mental health equity, reduce stigma, and build community and academic partnerships. And this is just a quick video to show who consists of or who makes up our coalition. And so over the last 7 years, our coalition has been helping us to, get grant funding, and we write them into all of our NIH grants as really providing community-based leadership. And one of the proudest accomplishments of this work is that one of the churches with whom we have partnered actually created a freestanding mental health clinic called the Hope Center. This is actually a picture of the ribbon cutting ceremony when the Hope Center was opened in 2016. You see the First Lady of New York is there, the now Lieutenant Governor of New York. And the Hope Center provides 10 free sessions of evidence-based psychotherapy, ranging from IPT, CBT, trauma-focused CBT, and working now with Dr. Kathy Shear to provide prolonged grief disorder therapy to address some of the grief associated with COVID-19. And so because of its affiliation to a trusted church, the access has really gone through the roof, and people have utilized the services of the Hope Center and importantly are retained in care, and we are seeing significant reductions in depressive symptoms. The next thing that we kind of did through the coalition and really was the brainchild of Dr. Olajide Williams, who's a neurologist at Columbia, was to develop an institute for training community health workers, which we call In Touch. And so these church-based community health workers are trusted members of their local community who are trained in basic health promotion activities. This includes blood pressure and depression screening. They're trained how to deliver motivational interviewing. They're trained how to help patients navigate through the healthcare system. And importantly, they're enrolled through the New York State Health Enrollment Marketplace so that they can enroll uninsured New Yorkers into health insurance programs. And most of our community health workers have no prior healthcare experience. Here are the demographics of our community health workers. 100% identify as African American. Most are women. You see the average age, and you see again a very, very wide range of educational backgrounds, which is representative, of our target community. And to date, we have trained and certified over 152 community health workers. They have screened over 10,000 New Yorkers for blood pressure, and we are now leveraging them into a workforce for an NIH study, R01, focused on screening for depression and connecting people to care. This is a picture of our community health workers at Columbia's Wellness Center, where they're learning how to do blood pressure screenings. And so I just wanted to share a brief, about 6-minute video, which shows kind of the community health workers in action and shows some of the rationale. And this video is what we're actually using for a recruitment video for our R01.
How you face yourself in times of unrest becomes pivotal in terms of how you see yourself. The best of who you are doesn't usually rise in moments of no challenge. The best of who you are comes to the forefront in moments of challenge, and we are in some challenging times, beloved. In those moments where we feel like our backs are against the wall, where we are bombarded on every side, where chaos and calamity become our companions. Those are the moments we get to see who we really are. We're challenged on several fronts. The social unrest and injustice in this land. We are still plagued by the myth of racial superiority and white supremacy. That's one challenge, and it's a challenge that has never left our community. But on top of that, in the midst of that, we now find ourselves dealing with a plague of epic proportions, COVID-19. Life can be so overwhelming. Life can be so battering and bruising that pretty soon you feel as though chaos and calamity are your constant companions. Darkness begins to creep into your conscience. And with darkness comes those feelings of destruction, and the toxicity that runs rampant in your spirit can be so overwhelming. And in the midst of feeling overwhelmed, one day you look around and you look at your life and survey the landscape of your life, and you feel as though you are all by yourself.
You don't want people to look at you differently or begin to judge you in a certain way.
All by yourself. All by yourself.
Sometimes I feel like I'm preaching to myself.
My bouts with depression started in part because of my chronic health condition. I was born with a very rare disease known as common variable immunodeficiency. In a word, I was born with no antibodies. I've been a pastor, battling sickness, battling this disease, battling chronic pain, and still having to show up for people and preach and minister and teach. The truth is, I don't know or remember a week in my life where I did not have pain. But I remember hearing someone ask one time, what happens when the comforter needs comfort? What happens when the one who is always expected to show up for everyone else needs someone to show up?
Depression is a clinical condition that is the #1 cause of disability in the world. It's also the #1 cause of disability in New York City. So our team conducted the first ever study where we identified people with depression in the church. We worked with 3 different churches, one in Harlem, one in Brooklyn, and one in Queens. And across these 3 churches, where we screened over 100 people, 20%, 1 out of 5 people at these 3 churches had depression.
One of the things that Dr. Hankerson and I have done is that we have created a community health worker training institute, or center rather, at Columbia University.
My name is Calvin Mark. I'm a community health worker. I was trained by Columbia University Medical Center, which is a part of New York Presbyterian Hospital. The training was long and intense. It was an 8 weeks training course, 3 days a week, 2 to 3 hours per day.
The role of the church in the Black community has historical significance. It has been a place of solace, comfort, a place for guidance and spiritual wellness for generations.
Over 70% of African Americans attend church regularly. And this community health worker training center that we have is responsible for working directly with health ministries in the Black church and imparting skills and knowledge around different health screening activities, around different health counseling activities, and even around the enrollment of congregants into health insurance plans.
What they've been able to do is Columbia and with community health workers are form a network of support and care and concern that's been able to help countless people. But we cannot afford to remain silent. We cannot afford to remain embarrassed. We must seek out the services that are available from the institutions that are committed, but are committed to the healing that is necessary to keep my mind and my heart right, and my spirit right, and my soul right.
So that is because of COVID, we had to go all virtual. And so instead of recruiting in person, all activities, for this study are done virtual. So we had to create this video, and this is the first of our recruitment videos. We have others now, but this was the first. And so I certainly wouldn't want to present to the University of Washington, which really has transformed, mental health care through collaborative care, of course, without addressing sustainability. And so ways that we are addressing sustainability are several. And so for this study, which is again an NIMH R01, our community health workers are hired as part-time employees at Columbia. So this we feel like was a real win for the community. It also protects them in terms of being under Columbia's malpractice and liability insurance. And the intervention that they are providing is SBIRT. So we have, repurposed SBIRT for screening, brief intervention, and referral to treatment for depression. So SBIRT, of course, was developed for alcohol use disorders. And there is a literature of SBIRT for depression. And given that our community health workers were trained in motivational interviewing, we thought that this would be a perfect intervention to test in this trial. And so this study is a cluster randomized controlled trial that involves 30 churches. So half of the churches' community health workers receive SBIRT, and the other half receive enhanced usual care, which consists of up to 2 sessions of meeting with individuals to address some of their social service needs, connect them to care, provide psychoeducation about depression. Importantly, SBIRT is a billable service with Medicaid. So we're trying to create a business model of how this could potentially be sustained after the grant funding is completed. And then at the same time, we're engaging with policymakers, both at the hospital level, the New York State level. The New York State Office of Mental Health has been very interested and supportive in this, and is actually committed to a kind of community healthcare worker workforce focusing on mental health conditions. So this is really fits nicely within that paradigm. And then the SBIRT training is delivered by the New York State Office.
Dr. Hankerson, I'm sorry to interrupt. I wanted to mention that your audio volume has cut down considerably, at times to almost inaudible. Will you just test out talking again? Let's see where it's at.
Oh, I didn't realize. Can you hear me now?
Yes, that's good.
Okay, sorry. Maybe I got too far from the computer. Is that better?
That's good. Yes.
Okay.
Thank
sorry.
you.
Thank you for letting me know. And so we're almost done. So that's our attempt to address sustainability. So in summary, we've covered a lot of ground, but I think I'll leave you with three key points. Number one, reducing racial disparities in care is a multi-pronged issue. There's no silver bullet, but it's going to take multi-layered solutions. Churches and other faith-based organizations are really ideally suited to promote mental health equity, especially for African Americans, given their access, their reach, the fact that people naturally seek help from pastors and in churches. They're ideally suited to promote, mental health equity. And this notion of community partnered service delivery really embodies principles that we feel like can be scaled in under-resourced communities, such as community-based participatory research, implementation science, task shifting, and then ultimately building capacity in the target community. And so with that, I say thank you, and I'll turn it over to Joe to answer any questions that people may have.
Okay, great. Thank you, Dr. Hankerson. And I'd like to encourage participants to write in questions, comments, and we have time to go through several. So feel free to write them in. I'll just make a comment about how rapidly the research has moved from focus group to I guess I'll call it a clinical epidemiological study out of a clinical setting, assessing depressive symptoms, and now moving on to testing an intervention. With one setting having a longer standing clinic in place. So it's really moved rapidly from understanding potential barriers to delivering clinical services. And now a couple of comments and questions have come in. One question about the evidence-based psychotherapies that are delivered. The question is about, are the therapies culturally adapted or modified?
That's a great question. I'm assuming they're talking about at the Hope Center in terms of the therapies that are being delivered. Excuse me. They are not specifically. Myrna Wiseman and Leonard Verdelli train the staff at the Hope Center in IPT. We have trainers in cognitive behavioral therapy. And again, Kathy Shear is going to be implementing prolonged grief disorder therapy. But there is a specific awareness and incorporation of, a person's kind of spiritual beliefs. So one of the important things that the providers do is inquire about a person's spiritual life. They also specifically ask about the mental health impacts of racism. And they also specifically ask about social factors that contribute to a person's depressive episode. And so while we don't tailor it per se, I guess you could say that it's tailored by specifically addressing those three issues.
Thank you. So I'll move, maybe another question came in about service delivery. What are your thoughts, Dr. Hankerson? Could this be replicated for other racial and ethnic groups, such as Asian American or Hispanic Americans?
I certainly believe so. I'm delighted to be working with APA SAMHSA fellow, Dr. Kui Oh, who's Korean American, and she is doing a grant through that process to engage Korean churches. And there's certainly a robust literature on Latinx churches doing depression interventions. So I absolutely believe so. And similarly in synagogues. So some colleagues are engaging rabbis to try to provide services through synagogues as well.
Now that was a question maybe about translating the intervention to another setting, but what about translating what's delivered where you're working now? Do you think you could include assessment and treatment of substance use disorders? Would that be feasible? Is that a consideration? Yeah,
absolutely. And so one of the things that we like about Expert is because it was developed for alcohol use disorders. We are screening people with the audit C. So if we get enough positive screens from that, then we certainly are going to apply for an IAAA grant to do the same thing.
Okay. Several questions directly from Dr. Pamela Collins. So first question, I noticed your study explicitly includes prayer in the description. How is this integrated into the service?
Great question, Pamela, and great to hear from you. And so one of the ways that kind of spiritual practices were integrated or addressed in the motivational interviewing is that we conducted a lot of focus groups with the community health workers to see how elements around scripture and prayer, they suggested incorporating that into MI practice. And so, one of the principles in asking open-ended questions is that our community health workers specifically ask about individuals' spiritual practice as one of the many elements of healing. So that's one of the examples of how that has been incorporated.
And then a second question as well. What about the process of hiring the community health workers through Columbia? Are they grant supported? Are there other sources of funding? What are some of those details?
Sure, yeah. Well, it's been a long process, but everyone is hired through the R1. But there are actually two sources of funding for the community health workers. So they are trained and certified through intramural funding at Columbia. And we actually just got a $2 million grant from Pfizer to create a bigger cohort of community health workers. So through intramural funding and through Pfizer, and the community health workers, once they're certified, are hired through Columbia through the R01 for this.
And thank you for addressing these points. A question as well. You had mentioned hearing from Dr. Veith. Here's a question from Dr. Veith. Are the reported lower rates for depression in Black Americans skewed by lower access to epidemiological surveys and treatment as ascertainment limitations?
That's a great question and a great point, because most epidemiological surveys are that many people, folks of color, are less likely perhaps to engage in those type of surveys, and they also do not go into prisons or jails, which are disproportionately folks of color. So I totally think that sampling could play a part in the low rates of depression.
A comment came in about the social aspects of perhaps gathering together, if that's maybe a part of the behaviors that might be part of a CBT, getting together with people, maybe as in a behavioral activation way. Is that a unique strength of assessing for depression or delivering an intervention in a church setting?
Say that again?
Yeah, about there's a comment that came in about the social aspect of people getting together and how that might be related to change in behavior or behavioral activation, for example. And the comment was sort of just wondering about that being related to mental well-being. But I guess I wonder if it's maybe a unique strength of delivering a treatment in a place that's intended for people to get together.
Yeah, and I think that's a wonderful point. And I think the social act, that's been one of the challenging things of this pandemic, of course, is that for the last 18 months, churches have not been meeting in person. So they're just now coming back to meet in person. And I think that social connection was lost. And I think that contributed to a lot of, depression, especially in New York City in the early stages of the pandemic.
Well, we still have a couple more minutes to go through questions, and there are several pending that are in the chat now. I'm going to switch my window here to chat. So one question was, how was that church video? I was wondering about this as well for recruitment. How was the video distributed?
Yeah, great question. So distributed through multiple channels. So all churches now, not all, but the vast majority have Facebook pages. So we put it on the church's Facebook pages. We distributed it on the church's websites. The pastors at our church study sites actually played the video on Sunday service. And we also have access to the church's email list. So we distributed it that way. So multiple streams of distribution.
What were there barriers that came up with implementing the intervention when going to the churches? I mean, you mentioned one that came up in the qualitative interviews about not wanting to step in and leave. In other words, building something more durable and longer lasting. But were there other barriers?
No, absolutely. I think one of for example, a barrier I think is the pastors have so many responsibilities that sometimes if they're not able to commit to something, that they essentially are the champions, I guess, to use kind of collaborative care language. The pastors are your champions. And, we've had to pivot at times when a pastor has not had the capacity to commit to the study or really champion it in a way to really promote it.
It's like competing demands in primary care.
Exactly. I mean, a classic example of that for my K award, we proposed to train clergy in interpersonal counseling, which is basically a 3-session version of IPT. And when the grant was funded, they had all signed letters of support and they were on board. And then when the grant was funded, they said, we don't have time to do this. So we had to completely, and we really relied on the community coalition to change, and we had to pick a different intervention. And so we ended up implementing mental health first aid. So that's how I became very close with Linda Rosenberg and the National Council. And so we implemented mental health first aid through these churches, and it was very, very well received. But it again goes to show how, I guess, flexible you have to be in the context of kind of community-based work.
Well, that's really interesting. Adapting what you're delivering. I mean, I would assume maybe to a wider population, or maybe, or not just individuals with depressive symptoms.
Exactly. And that's what both the coalition and the pastors ultimately said, that they thought that mental health first aid, and again, it really spoken to the stigma around mental health, distrust with former mental health providers. They thought mental health first aid would be a good kind of first step. And it really proved to be successful. And the church that developed and created that freestanding mental health clinic was the church that had the most mental health participants. And that really created a groundswell that led to the pastor. And the pastor in the video that you just saw, he's the pastor of the church that created that clinic. So he speaks very openly, and he is the kind of poster child for a champion of an intervention, sharing his story, leveraging church resources that led to the creation of that freestanding clinic.
Now we just have a minute, Dr. Henderson, but a question about preferences for people in the community served. What have you learned so far about people's preferences about engaging with a community health worker versus maybe with a pastor, or directly with a psychiatrist or psychologist? Are preferences emerging? Do you have data?
Yeah, I mean, so we're in the kind of the start of year 2 of this grant, so we're just now actually recruiting people, but preferences are emerging. So we actually, when we wrote this, we thought that there were going to be 2 community health churches who attended the church that would be delivering the intervention. But when it was funded, both the pastors and the community health workers said that with an issue around depression, people may not want to talk to someone in the church because they don't want that person knowing their business. So we actually have one community health worker who's a member of the church, and then another who's a member of another church. So it gives people the option to speak to someone with some level of anonymity, as opposed to what we originally proposed. So that's one preference that is emerging, through this.
It's interesting, adapting the study design. You give 2 examples of that in recent studies. Is that a feature of the participatory research design? Is that
to a degree, yeah. No, so for my K award, I had to go to my program officer and basically write a whole IRB protocol, get her approval. For this, we also are adding the GAD-7 as a screening instrument. So we're going to be looking at depression and anxiety, and had to do the same thing with the program officer. So it does require flexibility and lots of IRB modifications.
Well, great. I acknowledge there were a couple, I think 3 or 4 other chats or questions or comments that we just didn't get to. Here we are at 1 o'clock. But I do want to thank you, Dr. Henderson. Thank you for joining us and for presenting today, describing your research and currently what's happening with now in year 2 of a cluster randomized trial, which will all look for results in a couple of years. But thank you again.
Thank you so much. It was my pleasure.
All right, take care.
Bye-bye.